distinguished panelists. And really, this is now our 8th neuroendoscopy webinar. Essentially is focused on residents and young neurosurgeons. And I'm sure that the experience of all the panelists is going to transfer to a whole group of young neurosurgeons and residents across the world. So over to you, Jim. Please take over as the moderator. Thank you very much. Dr. Chandrasekhar hasn't been able to join us because he's still in the OR, but I'm sure he will join as soon as he can. Thank you. Take over, Jim.
Thanks so much. For those of you that are tuning in, this is the WFNS Neuroendoscopy Committee webinar Series 8. And this is on endonasal endoscopy in the skull base, special consideration. I'd just like to take a chance to introduce everybody. My name is Jim Evans. I'll be the moderator for today's session. I'm a professor of neurological surgery and otolaryngology and chief of the brain tumor division, as well as the director of cranial-based surgery program and the fellowship here at Thomas Jefferson University in Philadelphia. I'd just like to thank the WFNS and the neuroendoscopy co-chairs, Dr. Qureshi and Dr. Deepajari, for having us participate in today's webinar series. I'd like to thank the participants who are all logged on from I think, various time zones. In particular, to thank each of our speakers for taking time out of very busy schedules. I know each one of these guys, and I know they're quite busy, and they're all very happy to be here to present today. And they're all also coming from very different time zones. So I'd just like to thank each of them for coming. And if I could just take a minute to introduce each of the speakers. I'm sure you know who they are, but I'll run through if I could. Dr. Harminder Singh, welcome, Harman. He graduated from neurosurgery residency at Thomas Jefferson University in 2010. He completed a fellowship in neuroendoscopy with Ted Schwartz and Cornell in 2016. And he's currently associate professor of neurological surgery at Stanford University. And he's the chief of neurosurgery at Santa Clara Valley Medical Center. He has a particular focus on endoscopic skull-based surgery. And today he's going to lecture on endoscopic endonasal skull-based surgery in children, the anatomical considerations. Next, I'd like to introduce James Liu. Jim graduated from neurosurgery residency at the University of Utah in 2006. And he completed his fellowship in skull-based surgery with Dr. Johnny Delishaw in Oregon in 2007. He's currently professor of neurological surgery at Rutgers University in New Jersey in the US. And he has a focus on cerebrovascular as well as open and endoscopic surgery. And he'll be lecturing on endoscopic endonasal surgery in children, the surgical experience. So that should complement well after the anatomical experience. Dr. Davide Milani, I think he just logged in. Yeah, he's here. Graduated from neurosurgery residency in Milan in 2011. He's currently an adjunct teaching professor at Humanitas University in Milan. He works with a very strong multidisciplinary team, and his focus is in cranial surgery, in particular focus in endoscopic endonasal surgery of the cranial base. And he'll lecture to us today on endoscopic approaches to the craniovertebral junction. And then last but not least, Domenico Solari. He graduated from neurosurgery residency in Naples, Italy in 2011 under the guidance of Dr. Paolo Capabianca. And he completed his PhD as well as residency in maxillofacial surgery in 2016. He's got a very nice and broad background. He's currently assistant professor of neurosurgery at the University of Naples, Federico II. And he's going to lecture to us on complication avoidance and management in endonasal surgery. So with that, Harman, if you're ready, I'd like to start up with you. If you want to take over the screen with your slides, is that okay?
Yes, thank you, Dr. Evans. Let me see if I can share my screen here. Good morning.
I want to thank Dr. Singh particularly. He's coming to us from 4 a.m. Looks like he's in sunny Hawaii or something behind him there. But he's coming to us from 4 a.m. from the West Coast. So Harman, thanks so much for getting up and getting going. I know it's about 15 minutes before you'd normally get up.
Thank you.
That is correct. It is sunny in California. I apologize for my casual attire here, but I am in California. But I was up pretty late last night, and like you said, it's 4. So But thank you for having me, and I would like to thank the World Federation as well as Dr. Deo Pujari for the invite. Let me see if I can. Are you guys able to see my screen?
No, not just yet. We're looking at just the rest of the group here right this second.
Yeah, I'm trying to share here, but let's see if it. Yeah, I'm not sure why it's not letting me. Okay, I see it. All right.
Just while we're setting up, I just want to make one comment, which is to the participants. You have the ability to send questions if you'd like, or comments through the chat. We'll try to do the best we can to field those questions, and they can be to any of the lecturers or speakers today. And likewise, those of you that are on as speakers, feel free to make a comment or question at the end. We encourage you to do so. Thank you, Harman.
So,
Dr. Evans.
Yeah.
Just a second, there is also Professor Cavallo that would like to cheers, all of you.
Hi, James. Hi, everybody. Good to see you.
How are you, Luigi? Good, great to see you. Thank you for stopping over.
No, perfect. Very nice to see you.
Great to see you as well. I hope to see you in person soon.
Of course. See you, my friend. Bye-bye.
Okay, bye, Luigi.
Thanks to all.
Thank you.
thank you, Dominica, also. Let me just start. I think if you guys can see my screen now, the topic I've been assigned to is the anatomical considerations for endoscopic endonasal surgery in the pediatric population. So I have disclosures that are not relevant to this talk. I do get royalties from TEMA for our book. Just some anatomy and looking at the pediatric skull base and how the development works. The pediatric skull base development is asynchronous and asymmetric. It's a gradual age-dependent process that significantly alters endoscopic endonasal pathways as the child grows. And the anterior portions of the skull base develop and expand through the entire childhood. The posterior areas finish development much faster. So the way the brain and the skull base is developing is asynchronous. And if I can point to our picture here, the frontal lobe development pushes down on the skull base from the top. And the blue arrows show the sphenoid sinus and the frontal sinus pneumatization. The pneumatization starts from an anterior to posterior direction as the child grows, and from a caudal to a cranial direction. Also, while this is happening, the sphenoid sinus is also expanding laterally at the same time, opening up new paracellular pathways to the skull base. Also in green here is shown the development of the midfacial maxillary complex. Again, the development is from caudal to cranial and also from medial to lateral. And what that does is it pushes the carotids laterally, opening up this corridor that we can utilize then to operate on the skull base. It also pushes the optic chiasm up superiorly, opening up additional pathways inferior to the chiasm as well. So these are the forces that are driving the development of the child as the child is growing. My colleagues at Cornell, led by Dr. Greenfield, did a series of beautiful papers on measuring the pediatric skull base as it is growing, and a series of radioanatomical measurements. They define 3 different parameters. There are drilling parameters, restriction parameters, and working parameters. And we'll briefly talk about them and see how they affect the access to the skull base. So in the drilling parameter, they are looking looking at the height of the sella, the depth of the sella, the width of the sella, or the sphenoid, I'm sorry, and then the volume of the sphenoid as the child is growing from 2 years to 16 years of age, and see how that is changing over time. And then also the sellar width here. So the sphenoid volume, sphenoid width, the sphenoid depth, sphenoid height, the sellar width, how the sellar width changes. And then looking at restriction parameters at the nares where your instruments are going in children because the nostrils, the access points are small. Then also looking at the distance in between the terminates, the middle terminates, superior terminates that will restrict access to the skull base, the intracarotid distance, and as well as the angle, which is defined as the sphenoid angle, as to how your instruments are reaching the skull base. And then there is a series of working parameters, which is the sellar to nare length, the nare to dens length, the maximal reachable zone of the dens. What's the lowest portion of the dens you can reach using straight instruments? And we have done also several papers on this with the Jefferson group with Dr. Evans, looking at in adults how inferior access we can obtain in the cervical spine through the endonasal approach. So similar work in the pediatric population here. And then also the distance from the nair to the back of the skull base. So just looking at this in a chart form, this is the first set of parameters, the drilling parameters. So we can see that the height of the sphenoid, the length, and the width of the sphenoid, including the volume, is going up as expected. And there's they measured in a series of their patients with MRIs, and it goes from about 15 millimeters to 25 over the age range of from 2 to 16, and this is expected. But if you look at the sellar width here, that's the width that I was talking about here. There is not a whole lot of change. There's a change from 2 to 4 years to 5 to 7, where it goes from about 12 millimeters to 15, but then it is pretty stable throughout the growth, about between 15 and 16 millimeters. Now looking at restriction parameters, you can see that the intracarotid distance here between the two carotid arteries, which is an almost absolute limitation in pediatric surgery as to how lateral you can go, also increases quite rapidly from 2 to 4 to 5 to 7, and then still gradually increases, but not a whole lot of change from 5 to 16 years, from about 13 to about 15 millimeters. The transsphenoidal angle is the same. It increases quite rapidly up to 7, and then it flattens out. And now looking at the last the channel, the working parameters, and the same thing, the sellar nair, the nair sellar distance, the nair dens distance. These are all gradually getting bigger as the child is growing and the maxillofacial complex is growing. But the maximal reachable zone of the dens stays quite constant. Is how much can you remove of the dens using straight instruments, which is the top 12 to 13 millimeters. And of course, we have techniques of reaching lower using angle drills, angle instruments, but this is essentially used radio morphometric measurements. The nair vomer distance and the vomer Kleiber distance also they measured. And what was the gist of it? If I was to have one take home for practitioners who are starting to delve in pediatric endoscopic surgery, what age range is comfortable to start off? I would say that from 2 to 4 years, because of the pneumatization patterns and the size restrictions, this is the hardest part. Of course, we have done patients as young as 2 years. My colleague, Dr. Miranda, just did a craniopharyngioma large in a 2-year-old kid a few months ago. But from 5 years onwards, the experience is quite similar to that of working in an adult, albeit there is your working channels are smaller. But from 5 years onwards, it's safer in a child for adult practitioners who are starting to do pediatric endoscopy. So what we have found out is that while patient age and size is not a significant limitation to the endoscopic endonasal approach, the two things that predicted better outcomes in the series are a wider intracarotid distance. So that distance, if it is more than 13 to 14 millimeters, the morbidity was less, and a shorter dense nair distance. These two parameters predicted better outcomes and fewer complications. This is again in pictorial form, looking at the pneumatization of the sinus from anterior to posterior and from caudal to cranial, and how it opens up channels. And it's, I think, worthwhile looking at the different sphenoidal pneumatization patterns as they have been described. And this is one of the classifications from the literature, where there is the conchal pneumatization, where most of the space in front of the sella in a child is still this cancellous bone that you have to drill through to get to the sella. It's a relative contraindication because this bone is fairly easy to drill through. Type 2 is the pre-sellar pneumatization. Then there is the sellar pneumatization. And these three are the ones that we most commonly see in kids. And then there's the type 4A and 4B, where it's post-sellar, and the pneumatization extends posterior to the sella over here. So with that in mind, they looked at their series of patients, and we see that in the 2 to 4 year old group, a majority of the pneumatization is the conchal type of pneumatization. But as soon as the child gets to 5 year range and higher, then you get into pre-sellar and sellar pneumatization, which makes access easier to the sella. And a couple of other things to keep in mind when operating on children, and taking down the nasoseptal flap. It's still the work for reconstruction even in kids, and you can take a pretty large flap to cover a majority of your skull base and do the reconstruction, just to be aware of the vascular supply. And in the pediatric population, to be mindful of the maxillary crest growth plate, so not to swing the nasoseptal flap and take the floor to make a larger flap and damage the maxillary crest growth plate, because that can cause problems with the child's facial development. So just something to keep in mind. And then the ophthalmic epithelium at the top, which can impair their sense of smell. So in the pediatric population, just these a little more mindful of these two areas of development. And this is something that has been described in the past by other groups, where you can, once you have taken the posterior 1/3 of the cartilage, septal cartilage, you can swing the contralateral nasoseptal mucosal flap to cover the denuded septum here, and that can prevent or lessen adhesions in the child. So that's one of the techniques that you can use. So those are a few main things that to keep in mind when starting off in the pediatric population. And I'm just going to follow with 2 short cases, and then if we have time, I have 2 videos, about 8 minutes to finish off the talk. So this is a 7-year-old female with a large cystic craniopharyngioma that was previously, she underwent an endoscopic intraocular biopsy at an outside institution with cyst fenestration and a shunt placement, but she continued to have memory problems. The cysts kept getting bigger. So the decision was made to do an endonasal approach for her. And you can see in the orange arrow here pointing to the conchal pneumatization, where all this cancellous bone will need to be drilled away before you reach the sella in this case. And here the tumor is extending into the third ventricle, and also there's invasion of the hypothalamus. So there are some nuances in cranial excision in the pediatric population that I'll just briefly go over. Most of these are at an intenomatous subtype in the pediatric population, and the hypothalamus is very commonly involved in majority of these cases, almost 90% of the time in some of the series, and usually these tumors in the kids have solid and cystic components, whereas in adults they tend to be more solid. And the pitfalls of aggressive resection in the pediatric population are that because of the hypothalamic involvement in most of these cases, the injury to the hypothalamus can cause severe neurocognitive development, debilitating neurocognitive impairment in the child, as well as cause obesity, hyperphagia, thirst deficit, and the others. So trying to go for a gross total resection with hypothalamic injury is in a pediatric population causes a lot of morbidity. Injury to the mammary bodies can cause also cognitive and memory impairment, and the stalk is frequently involved just as in adults, so of course can cause postoperative pituitary dysfunction. So gross total resection mortality is as high as 20% in some series with high recurrence rates, and majority of these patients are needing hormone replacement and going to permanent DI. And hypothalamic invasion, if it's greater, is associated with even worse outcomes. So the key takeaways for pediatric craniopharyngioma for me are that as the natural history of this tumor is recurrence, it may be considered a chronic disease with the goal of maximizing control but minimizing child morbidity. And that hypothalamic injury can lead to severe functional impairment, and so it should be avoided even if it means leaving a residual tumor behind. And in cases where you can get a gross total resection, but it necessitates truncation of the pituitary stalk, that we have sacrificed if it allows for a gross total resection. However, if there is hypothalamic involvement, we always leave residual behind. And the endoscopic approach is feasible for kids as young as 2 years old, even when the anatomy is restrictive. There's an algorithm that we define in our book. And in this case, we operated through the transtuberculum approach. And I'm just going to go through a few still images here. So this is the, as you can see, the blue arrow pointing to the conchoid pneumatization. This bone is pretty spongy and it can be easily drilled away. So it's a relative contraindication. And once you have the sella, the tuberculum, and the planum exposed, we like to make the cut above and below the intracavernous sinus, expose the pituitary, the optic chiasm here, the pituitary stalk, and then the tumor is behind the stalk, going up into the third ventricle, and removal of the tumor. And even if with stalk preservation surgery, we are still, in majority of the cases, there is hormonal problems after, even if you're trying to preserve the stalk and peel the tumor away. The closure is using standard gasket seal. So here's the pre-op and post-op. So, majority of the tumor we removed, but of the hypothalamus, we left a thin rim to preserve function in this child. And then the gasket seal here, where you can see the Medport black graft with the nasoseptal flap enhancing in the front. So one more case quickly to go through. I think this is a patient with a young patient with a Chiari. Another speaker is going to talk about craniovertebral junctions. So I'm just going to go through this quickly. I'm not going to go into much details about it, but presenting with progressive dizziness, blurry vision, daytime somnolence with 60 recorded episodes for central sleep apnea during the test. As you can see, quite severe compression of the brainstem. So there's a series we have treated with anterior and posterior approach. with the odontotectomy, as well as a posterior decompression fusion to the approach. And in the pediatric population, you just have to be mindful. Sometimes there's adenoids in the way that have not been removed. So when you're approaching the clival junction, the adenoids will need to be removed. And then you just like to work through a vertical incision through the pharyngeal musculature to expose the C1 ring and the clivus, and then use just a suction for dynamic retraction as you're drilling away the odontoid and removing the muscular attachments of the apical and alar ligaments here, and then detach the odontoid peg at the end so that it's not moving around as you're trying to dissect the musculature around it and remove it. Then you see the dura behind. And the closure is pretty straightforward just because the pharyngeal musculature is pretty thick, just one stitch through it, and then I just leave some gel foam there and it heals really well. We used to put a fibrin sealant on top of this, but in one case, we had a child who, after extubation, post-op day 2, ended up aspirating the fibrin sealant, and we had to re-intubate him. So since then, we don't use any sealants there, and most of our patients are extubated the same day or the next day, and they start bleeds the same day as well. So there's a series of 7 that have been published as young as 7. And we look at the T2 signal in front of the brainstem and how the approach relieves the pressure. The setup is a little different because we have started using a CT scanner now to do these cases. This is when we used to do it without the intraoperative CT scan. So with the CT scan, both surgeon and assistant stand on the same side while we are doing the operation. It has led us to do intraoperative scans to see how we were proceeding with the resection. And what we found was, in most cases, for a right-handed surgeon operating through the right nostril primarily, there was a tendency to leave tissue on the contralateral side. Again, your exposure, if you're working through the right nostril as a right-handed surgeon, it's easier to retract that pharyngeal musculature on the same side with the suction and then through the drilling, while the overhang is so much on the contralateral side. So something to pay attention to as you're doing these cases, to also pay attention to the contralateral side. Dr. Evans, let me know if there is time for 2 videos. There's 4 minutes each, or if you want to save the videos till the end.
But I think, Harman, this is fantastic, by the way. Thanks so much. What I'd like to do, if it's okay, is why don't we make a transition, or see if anybody has any questions, first of all. We'll make a transition, and I've made note of that. And I think we're going to have time at the tail end, and we could go through those. Would that be okay?
Yeah, I have about 2 videos, 4 minutes each. So if there's time at the end, we can go through them.
Yeah, I think we will. But just to be courteous to everyone, so they have a chance to go through their presentations, et cetera. And then I'll keep note of that so we can go back. Is that all right?
Yeah, great. And then I would like to just thank the Jefferson team with Dr. Evans and obviously the PL team. They have been my mentors. So if I don't get back to you at the end, I just wanted to make sure that acknowledge. So thank you, guys.
No, I think we'll get back to you for sure, Harman. So just sit tight. But thank you so much. I don't see a lot turning up in the chat as far as questions for Dr. Singh. I'd just like to open it up to the rest of the panel. If anybody has any questions or comments for Harman.
I would like to congratulate, because it was like a beautiful speech and it was so balanced. Like that analysis that you performed, it's so amazing. And also the nice case, I took a picture of that craniopharyngioma case of the 7-year lady. Fantastic approach. Congratulations. Also to Juan, of course.
Yeah, thank you. Yeah, of course, he has joined us since last year, so that's been great too. And we have started doing our skull-based course now also once a year. Of course, this year we couldn't do it because of the pandemic, but hopefully starting next year. So yeah, it's been, I think initially when we started doing the pediatric cases, there was a lot of apprehension, but like I said, if for people starting out, you just have to be careful in the 2 to 4 year range because that is quite challenging. But otherwise, after that, the contraindications, you can drill through all that bone and reach the skull base. It's not really it shouldn't be that big of a deterrent as long as you have a good setup and a multidisciplinary team.
May I ask you also just a quick hint? Do you use fat like closing before the nasoseptal flap?
Yeah, so I don't use fat anymore, especially in craniopharyngioma cases where the arachnoid and the dura is widely open, because there was 1 or 2 cases where the fat migrated into the third ventricle and caused problems. So we have not used it. But if it's a large adenoma that we are removing, but the dura is intact, then you can use fat to plug up some of the space. But we have not used fat if the arachnoid is widely opened, especially into the third ventricle, because of that 1 or 2 cases where it floated back and into the ventricles. So so we just use the fascia lata with the Medporg. Sometimes you can't use the Medporg because the defect is so big and uneven, and then in those cases, you use the button layer technique that Dr. Evans had, and that works really well because you can layer it inside and out, and works great.
Thanks a lot. Really congrats.
Thank you.
Well, I just want to comment as well, if that's okay. As far as fat, we don't use intradural fat as a rule. The one place we'll use it, I think you alluded to, and in your last case is a good example. If there's some dead space, maybe taking out the odontoid, or if there's a very large clival dead space, and sometimes that can be helpful to fill that space and avoid volume loss. In the lower end, it's for swallowing, and the upper end, it's so that your flap can sit nicely across and not lose a lot of volume. So I think that's helpful. And how about lumbar drain usage, Harman? We don't use them as a rule.
Right, yeah, I mean, that's how I trained when I was there at Jefferson, but for craniopharyngiomas, I do use a lumbar drain. I put it in and I leave it in for 24 hours, and that's what I have done. Of course, we have the data now coming out of Pittsburgh where in the pediatric population, and we have a chapter of this in our book where they used it in peds, and they didn't see a difference in terms of leak rates. But I think that is because with the multi-layer reconstruction, the leak rates have dropped so dramatically that unless you are looking at a 500-600 patients in each group, it's hard to then it's not powered enough to see that difference. But that being said, I don't think you do it upfront in all cases. You can just wait and see if there is a need and do it later. I remember at Jefferson in a couple of handful of cases, we had to go back in later and put the drain in if there was a leak, but not up front we didn't do. So we saved a lot of patients the drain up front. So I think that is definitely something that can be, be part of your algorithm. But for craniopharyngiomas, I do, but I've stopped doing it for large adenomas and things like that at all. I don't do that up front anymore, no lumbar drains.
Does anybody else have any questions or comments from the group? Jim?
I think one thing you have to consider is, especially in craniopharyngiomas, if there is any preoperative hydrocephalus. Sometimes you have these large tumors that grow superiorly obstructing foramen Monro and have hydrocephalus. In fact, we have a patient that we're doing this morning with the same case. And in this case, we're going to put an intraoperative external ventricular drain up front. And I think those cases, if you're considering them for endonasal surgery, I think they have a potentially higher risk of postoperative CSF leak if they have preoperative hydrocephalus. And we've seen one craniopharyngioma case that ended up having not a frank leak, but pneumocephalus, in which case, I ended up putting a shunt and then redid the repair, and then he ended up doing fine. But I think pre-existing hydrocephalus is a concern when you're doing endonasal surgery.
Yeah, when the kids arrive to us directly, we do something very similar, Jim. But I find when the children are transferred to us, they're often shunted somewhere. They'll see the hydrocephalus, the local surgeon put a shunt in them, and they'll send them over for the big tumor. And so they've kind of got the shunt in place, which I don't really like, because I think they also run some infection risk, having the shunt in there. And you're looking up at this tubing sometimes through the framing, and I don't feel so good about that. But that being said, I haven't had them get infected after taking out the tumor, but that's another consideration, I think.
It makes you very prayerful during the post-op period.
I just have one more comment for Armin. I do want to move on to Jim. In addition to the maxillary crest growth plate, I know that's one of the limitations we've got to be mindful of, so for the maxilla and the septum. But do you have any other areas that you guys have come upon in your study that are critical, like for development, or areas that need to be carefully considered prior to making a wide or more expanded endonasal opening?
Yeah, I mean, we are pretty conservative, in our practice now in terms of how much septum we are taking in the kids. So we try to limit that. But in general, I think for larger flaps, if we need, then we do the Janus flap as has been described. Take both sides and swing those instead of trying to sweep at the base of the nasal floor, because then that carries you across the maxillary crest growth plate and can cause problems. So that's the only modification, but just be more mindful of also the olfactory epithelium at the top, not to carry it too far high up. But in a couple of cases, if you're too aggressive with taking the septum, they can develop the bridge nose, where then they come back as they're growing, and then there is a dimple in the nose. And but that has happened very rarely, and in one or two cases, ENT was able to go and reconstruct that. So, but that is something to be mindful of, especially in a younger patient where you're putting the endoscope in, and if you're, wedging it or you're using it as a fulcrum to reach areas, and then develop this deformity as they get older in the nose. So that's something to be mindful about.
So again, Harman, thank you so much. Great presentation. I really congratulate you on all your work. I think we should change gears if we can. Jim, if you're ready, I'd like to have you take the screen and go ahead and start your presentation. Thanks, Jim. And once again, for the participants, if there's any questions or comments, please feel free to send them in the chat, and we'll try to cover them as much as possible. Thank you, Jim. Go ahead. Jim, if you're trying, you're on mute, just so you know.
Okay, can you hear me? Sorry about that. Can you hear me now?
Yep, loud and clear. You're
Okay.
good. Ready to go.
Okay, great. Okay, so I'm going to talk about our surgical experience in pediatric endonasal skull-base surgery. And, the endonasal approach has become increasingly favorable over some traditional open approaches for various skull-base lesions. And you can apply them to the pediatric population as well. However, this treatment option is not always offered, even in specialized children's hospitals and also by some pediatric neurosurgeons. And so we evaluated the indications, surgical outcomes, and complications of pediatric patients who underwent EEA in our institution. We looked at our prospective database in a retrospective fashion, and we looked at patients who were 0 to 18 years old. and we looked at the following factors of presenting symptoms, pathology type, surgical corridor, and post-op complications. And we identified 21 patients who underwent 30 EEA surgeries in the study period, half female, half male. Mean age was 15, ranging from 13 to 18. So we didn't treat any small children, but mostly adolescents, and the mean follow-up was 38 months. In terms of the variety of pathologies, it was spread between pituitary craniopharyngiomas and JNAs, and a couple of sort of a potpourri of other types of pathologies like meningiomas and odontoid pannus and so forth. And we basically had covered all the major endoscopic corridors in this experience. 4 cases were combined with an open approach in a multi-staged fashion in some of them, mostly with large JNAs. We had 1 invasive anterior skull-base meningioma that was combined with a transbasal, and 1 extensive chordoma that was combined with a transclival with a posterior transcondylar approach. In terms of extent of resection, 11 achieved gross total, and some we left small residual due to adherence to neurovascular structures. So we have to be mindful and attempt maximal safe resection, not to harm the patient. In our series, 4 patients had recurrence. This was seen in 1 JNA, 2 chordomas, and 1 osteoblastoma, underwent repeat and a nasal resection. In terms of post-op complications, there was a 6% CSF leak rate, one of which was a recurrent chordoma that was already irradiated. So these can be difficult because the nasal septal flap had already been used. So we had to use a inferior turbinate flap. 1 was a JNA combined approach. We didn't have any visual worsening in our series or any vascular injuries, fortunately. So the transcellular corridor, as you know, is the workhorse of endoscopic surgery. And I just go through some case examples. This is a 17-year-old female with really florid Cushing's disease. She had central obesity and acne. You could see the adenoma here is eccentric to the left side. And so this is the standard endonasal approach, opening of the sella. And it's important on the Cushing's cases to open the sella widely. And here we're just opening the dura, and you can see the tumor is already extruded here, the soft part of the tumor under pressure. I try to open the dura without opening the gland, but in some cases that sometimes the pseudocapsule is entered inadvertently, or the tumor is just quite soft and suckable. So here we're opening up the dura widely. I like to open it in a stellate fashion in multiple directions. You can see the tumor type here, the consistency here is the typical soft, very suckable tumor type. So very easily to be removed. I know that in Cushing's, you often get into a lot of cavernous bleeding. And that's because the tumors are small and they tend to be eccentric to one wall of the medial cavernous sinus. So, but it's just venous bleeding. We just work through it. I don't use a lot of Surgiflow and that sort. It tends to obstruct my view, so I tend to work through the bleeding. And then at the end, I'll pack it off. But here we're removing the last portion of the soft tumor. And the key point here, what I want to show is here's the removals. You see the empty cavity, but this is a Cushing's case. And as Dr. Oldfield taught us, we have to get pseudocapsular resection. Now, in this case, I didn't have pseudocapsule because the tumor broke up on me. So what I'm going to do is I'm going to make an incision through the gland. You can see the gland is up in the right superolateral aspect. And I'm going to take this arachnoid knife and just make a cut through the gland. And I'm going to look for the pseudocapsule. So this is what I call a secondary pseudocapsular resection, where You know, sometimes we're not always perfect in keeping the entire tumor intact, but you can go back and look for the pseudocapsule secondarily. So here we are. I made a cut through the gland, and you can see I started to find some more firm tissue that looked like pseudocapsule, and then developing this plane with this spatulated dissector using a little bit of suction retraction. So here I have the handle of the pseudocapsule in the pituitary in my right hand, and then using the suction to gently sweep and develop that plane between the pseudocapsule and the normal gland. So I think you have to do these on these Cushing's cases. Otherwise, you may have a risk of having persistent hypercortisolemia and not getting a biochemical cure. So I'll just move this along. So we peeled off that pseudocapsule, and I think this is the end here. And then I take this alligator microforceps to remove any suspicious remnant tissue. And if you like, you can also shave off a little bit more gland and explore these parts of the gland. And this is what we typically do. And so here's a little bit of remnant left. And you can see this is the final view here. And so we achieved a gross total resection. Here's the post-op scan, but more importantly, her post-op day 1 cortisol nadired to less than 1. So I was very pleased with this. And she had dramatic changes in her body at 3 months follow-up. Her acne had disappeared. Moon facies disappeared. So very favorable result. In the transplantum corridor, as you heard from Dr. Singh, we tend to see more pediatric craniopharyngiomas. And this is a case where you can see a mixed solid and cystic craniopharyngioma that extends quite high up into the, where the floor of the third ventricle has been elevated upwards. So we'll do the standard transplantum corridor. This patient had a very nice favorable sphenoid sinus. The thing about craniopharyngiomas is you have to look for these perforating vessels coming out of the superior hypophyseal, as you can see here, and they go up towards the chiasm. So you have to be careful and not violate the superior hypophyseal artery. You must preserve it so you don't get a visual deficit. And here, what the beauty of the endoscopic approach is, you have this great view of the hypothalamus and the area underneath the chiasm. And you can dissect directly on the hypothalamus with direct visualization so that you're not causing significant trauma with your instruments. And I think that's the major advantage of coming from below for these retrochiasmatic craniopharyngiomas. And you must resist the temptation to pull. So ensure that all the detachments are free from the hypothalamus before you deliver the tumor. And so that when you deliver the tumor, you're not pulling, you're just merely delivering it, as we're doing here. And here's the final view. Maybe if the administrative host can mute the rest of the... So here's the view of the hypothalamus. You can see this is a typical view that you see a little punctate stipulate petechiae on the hypothalamus. This is relatively standard. Here's the left ICA that you see in view here. And you must protect the membrane iliquis. You keep this intact. You see it's pulsating. If you keep this intact, you'll preserve the P1 perforators off the top of the basilar there. And of course, repair is always a challenge. So we typically do a fascia lata repair, a 2-layer fascia lata. It's not the button type, but we just do an onlay, and that's worked for us. And then a large nasoseptal flap. And I like to walk the flap down with a cottonoid patty to make sure it's making contact at every bit of the surface area, and then bolster it with Surgicel, gel foam, and a Miracell packing. And we leave the packing in for roughly 10 to 12 days and so forth. And in these cases, I do use a lumbar drain about 5 cc's an hour. Here's the post-op MRI. You can see the chiasm is well decompressed. And this is the patient, and follow-up has done well. Recurrence-free for the last 7 years, so he's done quite well. This is a case I did when I was a visiting professor in Mexico City. We did live surgery, and this was a case that they let me do. You could see in this case, this was an 8-year-old girl, and you could see the sphenoid sinus has not been completely pneumatized. You can see the calcium from this craniopharyngioma. So this required a little bit more drilling, and I think when you're using image guidance, I always like to use CT angiogram image guidance fused with the MRI, because when you're drilling through a lot of bone, you just want to know where the carotids are, and so CTA image guidance is quite nice. And this was the immediate post-op scan, and the delayed post-op scan. Here you can see there's no recurrence, so she did quite well from this. So you can see her nostrils were small, but we didn't have to make any relaxing alar incisions on this case. In terms of the transclival, you can see some pediatric chordoma cases, and they tend to be more aggressive, these pediatric chordomas, as we've seen in the literature, especially if they're poorly differentiated. So this is a case where the clivus is solid, but the tumor is all retroclival if you look on the T2 MRI. So this required a lot of bony excavation. There was really no pneumatized sphenoid sinus. That really made this case very challenging. So you have to work between the two paraclival carotids, but since it's not pneumatized, it's not well visualized. So I did not skeletonize the carotids just to avoid vascular injury, but it does make your corridor a little bit more narrow. But here we are, we've identified the tumor. And in this case, as you know, there's 2 layers of dura. There's the periosteal layer where this pearl of tumor is situated, and then there's the meningeal layer, as you see here. So this is the meningeal layer of the dura. And I know some of my colleagues advocate for aggressive removal of both layers, but in this case, I chose to try to avoid a CSF leak and just peel off the outer layer of dura. And you could see here's the post-op scan. We achieved a near total. There was some tumor just behind the petrous ICA, and but no complications. 4 years post-op, you could see there's some recurrence at the dorsum sellae, and also here at the petrous apex bilaterally. This is the area where I didn't go for broke and skeletonize the carotid. So on the return trip to the OR 4 years later, I was a little bit more aggressive, and I did a more aggressive clivectomy in terms of resecting the dorsum sellae. And so here is the tumor that's superiorly right here. This is the part that's at the dorsum sellae, just underneath the gland. You can see this is all extradural, so we could save the dura here. We did not have to do a transdural posterior clinoidectomy. It's not always necessary. Sometimes you just do what the anatomy gives you, and maybe that can avoid any pituitary dysfunction or intradural CSF leak. So it's important to use curved instruments. This is a curved suction using the angled 30-degree angled scope. So we're looking into that corner of the dorsum sellae, and then here we are drilling off the other posterior clinoid on the right side. This is actually the lower clivus now. You see how the dura has a convex shape? So this has more of a convex shape to it, and now we're drilling out into the petrous apex on the patient's right side using a curved drill and an angled scope, 30-degree scope. Here's the angled suction, so we can look out in here and suction this corner here behind the petrous ICA. And so I think with the use of angled instruments, you can do this. We encountered a CSF leak intra-op, so here's an alloderm patch graft. I know in Pittsburgh group has published experience with using transmaxillary approach to the contralateral petrous apex, and that's one option you can do as well. In this case, I didn't feel like I needed it. I was able to get enough reach with my angled scope and angled instruments, and this ended up to be quite successful. And she's been recurrence free now for the last 8 years. So you could see here I skeletonized the medial ICA and was able to get more lateral to the petrous apex. And this is her MRI scan, delayed fashion. You could see no recurrence, and she's done quite well. This is a 14-year-old girl with torticollis, huge chordoma. This was a poorly differentiated, and we did this through a transclival approach. And you could see the tumor is eroding the entire clivus. So you can see both hypoglossal canals in view. And then we did a stage 2 posterior transcondylar, midline posterior transcondylar during the same time as the OC fusion. But here you could see this, the VA here is completely skeletonized, and you could put an endoscope into this defect and reach around the vertebral artery and get the rest of the tumor. So we got a near total resection here. She underwent proton beam, and the tumors remained stable for the last 5 years now. Unfortunately, she developed metastasis to her hip and femur, and I suspect she's not going to do that great from this. Odontoid going lower on the skull base. As you know, this was very nicely demonstrated by Dr. Singh. I do want to show you this very interesting case. This is osodontoideum and Chiari. She had a prior Chiari decompression here, but look at the compression on the brainstem. I believe this was causing her syrinx, holo cord syrinx, that was driving her scoliosis. You could see in the mid view, but after decompression, you could see this is an immediate post-op MRI. This is not delayed, but look how the syrinx has already decompressed itself on post-op day 1. Quite remarkable. And at 3 or 6 months, you could see the scoliosis has corrected itself. So if you correct the syrinx early before they reach significant curvature, you can actually correct or stabilize the scoliosis. And this has been well demonstrated at the University of Utah literature by Doug Brockmeyer. And lastly, I want to cover the lateral corridors. We typically see JNAs in this area, and this is one of our former articles that we published on using multi-corridor surgery, because sometimes these go way out into the lateral infratemporal fossa, and although you can do it purely binostril, I find it easier and less of a struggle if you create a third window into the Caldwell-Luck maxillotomy. It just gives you more room and you have less sword fighting. So this is a case of a huge JNA going into the back of the nasopharynx. The patient was losing weight because he couldn't eat. So we had to take this tumor out. So we've created a septostomy window here, preserving the nasal mucosa. So this is a mucosal sparing septectomy. So you can go binostril. It's different from a pituitary where you're doing a posterior septectomy because the lesion is more anterior, because your use of 2 instruments going cross court is more anterior. So you make that septostomy, but you can still preserve the nasal mucosa. And you have to embolize these. These are quite hypervascular tumors, but even then they can still be vascular intraoperatively. So you have to cut off the blood supply early and go after the infratemporal fossa. So we're working here in the left infratemporal fossa. You can see the fat pad in the infratemporal fossa, and you want to look for that IMAX branch early on and coagulate it so that it makes the rest of the surgery easier once it's fully devascularized. So even with embolization, they can be quite bloody until you get to the IMAX feeder. And so with these large tumors, I do like to take them in stages. So sometimes I'll cut them in components. So I'll take out the nasal cavity portion. And then this is the inferior portion, the part that's in the back of the nasopharynx. So it was quite large and stuck behind the hard palate. So we just pushed it down and grabbed it with a ring forceps in the mouth and then deliver it from the oral cavity. So don't be dogmatic and say everything has to come through the nose. You can use the mouth, you can use the maxilla. Sometimes you have to do a craniotomy, and I'll show you this in the next slide. So the septum is replaced, And you can see we can suture back the mucosa and make his nose look perfect afterwards. So here's the post-op scan, gross total resection. The patient started gaining weight after he was able to eat. So this is the example where the tumor extends intracranial around the cavernous sinus. And although you can do it completely below, I'll tell you the advantage of doing it combined with above. And so we do this through an FTOZ, orbitopterional standard approach, extradural peeling of the cavernous sinus. So we're peeling off the lateral wall, and this exposes V1, V2, and V3. And then we drill the bone around V2 and V3 and expose the periosteum. Now, the major advantage here is if you do this from below, the back of the tumor is up against the cavernous sinus, cavernous ICA, and you don't have good control of it until the very end, and you don't see it very well. But if you do this from above, you can peel the tumor off of the cavernous sinus, protect and isolate the cavernous ICA, which we're doing here. And now that the ICA is protected and you have control of it, you have more freedom and confidence to come from below and know that the cavernous ICA is protected. So now we're coming in from below. We're going to debulk the tumor that's in the nasal cavity. You saw that we did a Caldwell Luck. So this is a 4-corridor approach, and the tumor is nicely devascularized, so it's quite open. And then we'll debulk and remove the nasal cavity component. Now we're going to turn our attention towards the lateral infratemporal fossa component. So here's V2, and here's a distal branch of V2 that we're incising. So V2 is now protected, and we're in the infratemporal fossa. This tumor was extending quite laterally into the buccal fossa and eroded inferiorly through the hard palate. So we're elevating the tumor off of the hard palate defect, coagulating the rest of the feeders, and then we're going to deliver the tumor from the maxillotomy. This is the Caldwell Luck maxillotomy, little sublabial incision. There's really very minimal morbidity from this. They get a little lip numbness, but quite well tolerated. And of course, it's less of a struggle. You have more working room and less sword fighting, and he's done quite well. This is the last case I want to show. This is another hypervascular type lesion, and this was hypervascular, and it was fed by the cavernous ICA. So when it's fed by the cavernous ICA, these are very hypervascular, and you cannot embolize them, so they're quite challenging. So if you, in a small child, you run into blood loss, you do have to stage them, pack off the nose, and come back another day. And so we ended up doing this in 4 stages. The first stage was we used a right maxillary endonasal approach and removed the lateral component here in the infratemporal fossa. We got into a lot of blood loss, so we packed this off. We came back to do the right modified OZ to decompress this part and to also peel it off the cavernous sinus. And then we came back, 3rd stage, and at this point it was a little bit less vascular, and we were able to remove this whole midline component with a binostril, but running into blood loss at the back of the tumor at the skull base, there's little perforators coming through perforations of the skull base, so we had to pack this off. And then we came back 4th stage to remove the packing, but there was actually a couple nodules that were left in little nooks and crannies that we were able to remove in the final stage. So multi-stage procedure. This is the final CT scan. You could see complete removal, empty nose, and here's the MRI pre-op and post-op, and here's the patient at 6 weeks follow-up. So he's done quite well. Just a little V2 numbness in the cheek, but he's cured. The last case here is this recurrent grade 2 meningioma. You can see it's through the transcribiform corridor. It goes wide over the clinoid. So here, I think a purely endonasal approach would not be very optimal. So here's a combined approach doing transbasal with endonasal, another example of using combined approaches. And here's the post-op scan, and he underwent radiation therapy because it was a grade 2 meningioma. So in conclusion, the endonasal approach is safe and acceptable for a variety of lesions in this pediatric skull base. We can get high rates of gross total with minimal complications with an experienced multidisciplinary team. And I think there should be more collaboration and engagement of dedicated skull-based teams with our pediatric neurosurgery colleagues, especially in the specialized children's hospitals. And I thank you for your attention on this.
Jim, thanks so much. That was just fantastic. Great videos, very clear and great videos, and clearly superb surgery. I don't see any chat questions from our participants, but do any of the faculty have any questions or comments to add? And by the way, Dr. Deepajari, nice to see you.
Yes, Jim, thanks very much for your participation and for looking after. I actually got stuck with a case and could just get out now. But I heard Jim's talk to some extent, and I think it's very nice. But please go ahead with your discussion.
Okay, thank you. Good to see you.
Thanks.
Does anybody have any questions or comments for Dr. Liu? I have just two things then, if that's okay, or maybe three. One is I've seen the same kind of thing with chordoma mets, Jim, that sometimes these are even scattered. I know that they're more aggressive in children. That case you had was quite aggressive, but sometimes they're scattered at the time of surgery. I had a patient that came back over 10 years after resection of a large clival cervical chordoma with no evidence of disease at the primary site. And he came back with a piece of chordoma in his elbow, in the soft tissue around his elbow. And we resected that primarily, and he's still doing fine without any radiation to the elbow or anywhere else. And it's thought that sometimes they scatter even in a less aggressive, quote unquote, less aggressive chordoma at the time we operate. They might disseminate a little bit, and just something I've seen as well. Syrinx, you showed a great example of that syrinx resolution. And I've seen the same exact thing. It's uncanny. You get a post-op scan within a couple of days or less than a week after surgery, and that syrinx is down, and the patients are less myelopathic. It's remarkable, I think. And you showed a great example of how quick that can resolve. I have a question. With the pediatric cases, do you use a smaller endoscope? We tend to switch to a 2.7 size endoscope where it's a little bit more limited, a little less light. We've gone as low as 1.9, but that is exceptionally limiting. And that's for the kids that are just in the few months old. The youngest we operated was 11 months. But I just want to get your thoughts on that. Do you swap, or do you still stick with your 4mm scope?
Yeah, I've not swapped, and largely because I don't think I've operated on young children less than 2 in our experience. We just haven't seen those cases. I think largely it's the referral pattern, and like I was trying to allude to in my talk, I don't know how it is in the rest of the world, but here, as you may know, in the US, we have a lot of specialized children's hospitals that are staffed by pediatric neurosurgeons, and in the pediatric neurosurgery training, fellowship training, they don't get a lot of endoscopic and nasal experience, because that's also very specialized in the way we're trained in the US with specialized skull-based fellowships. And so I'm trying to encourage more collaboration with our pediatric neurosurgery colleagues working together, or referral to the main hospital. So I don't know if that's an issue that is encountered by others, but it's something I wanted to raise in my talk.
No, that's very mindful. That's how it is here as well. We have a dedicated pediatric hospital, Nemours DuPont, and that's where the cases end up going. And we run the program there, although our main center is adult, like you're describing. And we work with our pediatric colleagues there, but we bring to the table the endoscopic, skill and the experience, and it works very well. But you're right; they often go to the pediatric hospital. Any other questions or comments for Dr. Liu?
Yeah, may I?
Please, yeah, Domenico, please.
Yeah, Jim, of course, congratulations for the speech. Very beautiful cases. And my impression is, my question is about the cross court that you showed. Like, my question is very basic. Like, since, like, I think you are using the 3 instruments technique, all of them like cross court. Like, the endoscope is in the opposite nostril of the tumor. Is it correct?
Yeah, I tend to, if it's purely binostril, we tend to put the endoscope in the right nostril, and I'm a right-handed surgeon.
Yeah. Did you ever try like to have the endoscope in the nostril of the tumor and the instrument coming cross court in order to slide forth and back in one nostril and have the instruments coming in front of you?
So I'm trying to understand your question. I usually put the endoscope.
The other nostril. Like, can you move your instruments in one nostril and then you have the endoscope in the other? Like in regular skull, I don't know. Like
Yeah, I use both nostrils for the instrument. So instead of single nostrils. So I tend to since I'm right-handed, I use the suction in my left hand in the right nostril and whatever dissecting instrument in the left nostril. And the endoscope is mostly placed in the right nostril, which is more comfortable for me, and it gives my working hand more freedom.
Okay. So
we've done that.
Court, you have the instruments, you have the endoscope in the opposite nostril, right?
Yes.
Okay, thank you.
Yeah, we've done every combination of it as well, Domenico, with putting two instruments down one side, endoscope on the other, in various combinations as well. And I think you just have to sort of keep trying until you get the right, angle or the right working freedom and that sort of thing. But I think probably like you're describing, get pretty creative with working back and forth, and even on opposite sides of the table sometimes.
Okay.
I find it's also helpful to not pin the head, where I can adjust the head a little bit to even have that advantage if you're careful. So we try to use various combinations as well. I think that's what you're describing, right?
Yeah.
Any other?
Not any left-handed surgeon with you.
That's the nice thing about working on both sides of the table, quite frankly, is you can swap that up very easily. In fact, when you swap and have a left-handed primary surgeon, like I've had two fellows that were left-handed, they can easily stand on the contralateral side, and a right-handed person can hold the camera on the patient's right side. And you can actually be very versatile that way, as opposed to when you're usually sitting on the same side, which many centers do. We tend to work contralateral.
Perfect.
It works pretty well.
Thank you.
Any other questions or comments for Jim?
Yeah, I think, great cases, Jim. I would agree, just a comment in terms of we have gotten some criticism about the odontoid resection, endonasal and pediatric, and the combined approach where there is this high level of invagination where sometimes people say you can do a posterior decompression and correct the deformity from the back, and then the brainstem compression will go away over time. But I have to say that, when you are directly removing that knuckle that's pushing into the brainstem, that does the kids respond amazing to that, and they do really well. And you have taken the compression away, and the syrinx gets better. The symptoms improve. So I think there is still a role for endonasal resection of the odontoid, even though a lot of people are saying posteriorly you can do it. But we have seen that, especially the 1.5 carry cases, it really helps to go from an anterior approach.
Some of that, Harmon, may draw from the literature from rheumatoid, right? Years ago, rheumatoid patients had their odontoid resected on a regular basis. When I was in London with Dr. Crockard, that was very common. And then, as you know, if you stabilize them, that settles down. And I think some of that probably draws from that type of experience, that if you stabilize posteriorly, you can reposition them, that you can reduce anatomically, and then functionally, that pannus will go down. So it might be some drawing from that as well. I just have one last comment. Sorry, go ahead, Harmon.
So, I mean, I have been to so many meetings in India, and I know Dr. Dev Pujari is there, and I would say that Atul Goel would invariably at one of these would say, "Oh, the anterior approach is a historic operation," and I always say, "No, for some cases we really need it, and it works well." So it's great to have the discussion. Yeah.
Any thoughts, Dr. D. Pujari?
Well, it's difficult to convince Atul, but though there is obviously some merit in what he is doing, I mean, most of the patients now we get for transoral or transnasal odontoid are patients who have had posterior surgery, distraction, fixation, and who are still progressing. And it used to be much more often, but today I think it has come down to maybe 2 or 3 cases a year. So it's a substantial reduction in numbers, but it still happens.
I have just one last comment, Jim.
Yeah.
In regard to the JNAs and the vascular cases, we haven't quite written this all up yet, but there's also the option of direct injection, like you can do for a carotid body tumor. You can actually do that with JNA, even though you may want to do your endovascular to try to take blood supply. And even when they look great after endovascular, right, they're pretty vascular tumors, and you need this centripetal dissection and really stay out of the blood supply because you often get to it later in the case. We have done endonasal injection, direct injection in the endovascular suite. And I will tell you, I have not seen anything like it. I'll show you some cases soon enough that look like they are completely shut down. And so you can do it in and of itself if it's a small enough tumor, or do an endovascular and then do an endonasal direct needle injection. And you can go throughout the tumor and you can extremely well shut them down with typically with onyx is what we've been using, and sometimes particle, but mostly onyx. So just another thought, if you're facing, pardon me?
You are using onyx for that.
Yeah, most often, exactly. Yep.
Okay.
And
So
it's go ahead, Jim.
Oh, why do you have to do it in the angio suite? Because you're checking from the carotid injections to see if there's any more filling?
Yeah, you're checking to see what areas need to be injected. And you also need to watch because you can also overdo it, right? You don't want this to extrav or to get out into the vessels and cause problems. Depends where you're injecting it. You can see this literally fill that tumor under direct injection, and you can watch all that enhancement that goes into the contrast going into the tumor just disappear. It's
So
pretty remarkable.
I worry about the cases that, you know, if it's primarily fed through external feeders, it's safe. But the ones that are near the cavernous that recruit Petrus ICA cavernous feeders, I worry about reflux into that. Have you used it in those cases as well?
Yeah,
Or?
and that's the point, is you can watch for that. You can watch as that contrast is getting close to it, because you've got both ways to watch it, under direct from your needle on the angio suite, as well as by doing an endovascular injection. And it's pretty remarkable, I'll tell you. Think about that, or talk to your angiographers about it, because it will help you. We've had some JNAs that I thought would be just a disaster, and they were just like taking out tumor without worrying about bleeding. It's pretty remarkable.
That's great.
Yeah, just think about it and try it. We'll show you some of the things we've been doing.
Yeah.
Nonetheless, we should probably move along in the interest of time. Davide, are you ready to share your screen and show us your presentation? He's going to present on endoscopic approaches to the craniovertebral junction. Thank you, Davide.
Okay, thank you very much, Dr. Evans. Thank you, Dr. De Pujari, for the invitation. 1 minute.
Davide, it's a little bit soft, like the microphone maybe has to come
Okay.
closer.
Yeah, you need
perfect.
to be louder.
Can you hear me?
Yes.
That's better. That's much better.
Okay. Okay, here I am. So, good morning, good afternoon, good evening to everybody. Thank you for the invitation, Dr. De Pujari. Thank you, Dr. Evans. So,
Welcome.
I will talk about our experience in the endoscopic approach to craniovertebral junction. My presentation is a little bit more basic than the previous one. Anyway, I will talk about my experience in odontodectomies for basilar invagination. What is a craniovertebral junction? Is a collective term that refers to occiput, atlas, and axis. Is the, as we know, is the most mobile segment of the spine. In particular, occipital C1 segment allows flexion and extension, and C1 and C2 segment allows axial rotation. There are a very important ligamentous apparatus sustaining the CVJ. In particular, I want to remember the transverse ligament, which resists to supraphysiological flexion of the CVJ. The alar ligaments, which arise from the lateral part of the odontoid to the foramen magnum, and they prevent supraphysiological axial rotation of the CVJ. And another important anatomical structure is the tentorial membrane, which is the cranial continuation of a posterior longitudinal ligament. And this is important in surgery because it protects the dura in the CVJ region. And from this point of view, odontodectomy is a quite safe intervention. We have to understand CVJ pathology. We have to know some craniometric point and measurement. As we know perfectly, we have here the nasion, the tuberculum cell, the basion, and the piston, and the posterior margin of the hard palate. So craniotomy is very important to understand CVJ pathologies. There are some lines particularly important. I want to remember the Chamberlain line, which runs from the posterior margin of a hard palate to the opiston, and the McRae line, which runs from the basion to the opiston. Another important measurement is the basal angle, which is the angle subtended by the junction of the nasion tuberculum and tuberculum basium tangents. If this angle is greater than 150 degrees, we have platybasia. What is basilar invagination or basilar impression? They are a condition in which the odontoid is more than 5 millimeters above the Chamberlain's line. Basilar invagination is a malformative condition. Often there are other malformative situations such as atlanto-occipital assimilation or chiari malformation, or other malformation of the bone component of the CVJ. And we can distinguish two types of basilar invagination. In type 1 basilar invagination, there is a direct upward displacement of the odontoid process into the foramen magnum. So the odontoid tip is above Chamberlain's lines and above McRae lines. And this type 1 basilar invagination is almost is associated with the atlanto-occipital assimilation. Then in type 2, on the other hand, we have an upward movement of all the CVJ towards the posterior fossa, and this malformation is often associated with the chiari malformation. And in this case, the odontoid tip is obviously above Chamberlain's lines, but it can be below McRae line, so outside the foramen magnum. Anyway, there is there can be neurologic structure compression. Basilar impression is an acquired condition, but I will not focus on this because very rarely we have to operate a basilar impression endoscopically endonasally. When a surgeon must to consider a surgical approach to basilar invagination, where there are important neurological impairment due to the compression of medulla oblongata and spinal cord, with motor sensory deficit, brainstem dysfunction, lower cranial nerve dysfunction, and so on. As we have said before, there is the classical approach of Dr. Goel with atlantoaxial distraction and fixation to resolve this condition. But sometimes posterior fusion and odontoidectomy are necessary, and I will focus on this. Historically, the transoral approach is the approach to the odontoid, but in the last 2 decades, as we know, the endoscopic transnasal approach has gained a wide wide use, and we know that the limit of this approach is the poor inferior exposure. In fact, we use preoperatively the rhinopalatine line to assess our possible caudal exposure. This line runs from a point at 2/3 of a line connecting nasion and anterior nasal spine and passing at the level of posterior nasal spine. And this is a pessimistic line and give us the possible lower limit of our exposure. So to increase, we think that we have to increase the caudal exposure of in this approach. We use a transeptal approach with posterior nasal spine removal to achieve this scope. First of all, in operative room, we use obviously neuronavigation, and we have the arm technology, so we can check at the end of odontoidectomy the extent of bone removal. And this is very useful because, as Dr. Singh told us before, the lateral part of the odontoid can be left in. So if you can check with the arm, you are sure that the odontodectomy is complete. Now we show our steps. I'm a little bit basic, but I think it's useful for young colleagues. We start with the longitudinal incision at the liver that in the septum, just in front of middle turbinate. The incision must go down until the hard palate. Then we elevate the mucosa and we fracture the septum and remove it. These are some pictures of these steps. At this point, after the removal of the septum, we gain access to the nasopharynx. At this point, we can see that the posterior nasal spine can prevent us to have a good exposure of C1 and C2. So we think that an extensive drilling of posterior nasal spine and hard palate allow us to have a better caudal exposure. In fact, if you remove this part of bone, we can see and expose much better C2. The CVJ steps of the operation are widely described in the literature. Now I will show you in this video our approach, the incision on the mucosal of the mucosa of the septum, exposure of the septum and the hard palate, fracture of the septum and removal. Then we will put back the septum at the end of operation. We make another contralateral incision on the other side of the septum mucosa, and then we perform the usual inverted U-shaped incision. We find that it's very useful to use laser in this situation. You have to be careful to the Eustachian tube. With the laser, it's relatively easy to detach and to elevate the mucosal and muscular flap and to expose the clivus and the C1. Then we have to drill anterior arch of C1. And at this point, we can expose the odontoid, and this is the clitoral membrane. We have to drill the odontoid and until we have only a thin bone, shell of bone, and then remove that easily. At the end of operation, we remove the tip of the odontoid, and then we have a good decompression. For closure, we use just we put back the mucosal flap, and there is a rapid healing of the wound. We put back also the septum, and at the end of the operation we put celastic lamina to favorite healing of the wound. So it is a relatively easy intervention, I think. And the ligament and the membrane behind the odontoid prevent, in many cases, complication of CSF leak. As we told before, the indication to this operation is very rare, very uncommon. We perform around 100 endoscopic procedure per year, but in the last 5 years we perform just 9 cases of odontoidectomies. The mean age of the patient was 63. We have operated 7 female patients, and in 7 cases there was type 1 basilar invagination. Okay, all the patients had neurologic problems of a certain degrees. We use European myelopathy score and Neuric score to score this impairment, and we had I think good results, in particular no CSF leak for this operation. We didn't have the typical complication of a transoral approach, so no patient needed perioperative tracheostomy or nasogastric tube feeding. And just in one case, we have a case of partial velopalatine insufficiency with rhinolalia. But I want to stress that all patients before odontoidectomy underwent occipito-cervical fixation. So we had a good neurological outcome, but we should face a poor quality of life for this patient with occipito-cervical fixation. These are some examples with pretty good removal of the odontoid. So, what can I say? Transnasal endoscopic odontoidectomy, I think, is a safe procedure, relatively easy, as I show you. The drilling of posterior nasal spine can overcome the problem of low caudal exposure. If you choose a transeptal approach, you don't need to remove middle turbinate. You can obviate olfactory disturbance and so on. And there is a less anatomical traumatism and less bleeding. As all endodontal approach, the problem is the lateral exposure, and there is drilling the hard palate a little bit. There is a risk of velopalatine insufficiency. But I think that the major limit of this kind of approach is the need of another operation, so the need of posterior fixation for this patient. Because if in the literature I reported some cases of anterior approach without posterior fixation, but I think that it's not the case, because we have unstable. If we have to operate, we have unstable CVJ, so an intervention cannot restore stability, and the posterior approach is needed in any case. I think I finished it. Thank you.
Davide, that was excellent. Thank you so much for presenting. I like your series, and all of your points are very strong. So thank you so much. Again, I don't think I see any chat questions from the participants. So I'd just like to open it up to our faculty. If anybody has any questions or comments for Davide.
I have a few comments and questions, Jim.
Thank you, Jim.
David, congratulations on a very nice presentation. I'm interested in the paper you presented with the wide corridor nasal spine. We do something similar, and we preserve our rhinologists are very take a lot of pride in trying to preserve as much nasal mucosa.
Yeah.
So we had published a paper on mucosal sparing posterior septectomy. So when we're doing the septectomy, we're only removing the bony cartilaginous component, but sparing the mucosal
Yes.
side, which can be reapproximated. Do you do something similar like that as well?
Yes, our ENT surgeons too want to preserve as much as they can. So we need just 2 vertical incision, and that's all. We remove the cartilaginous and bone septum, and then we put it back. The 2 vertical incision are on the right side a little bit anterior, on the left side a little bit posterior, so there is no problem of healing after operation.
Yeah. Terrific. And the other comment I wanted to make was yesterday, actually, in fact, I did a case of a large pannus. It wasn't basilar invagination, but it was a compressive pannus that was just at the plane of the hard palate, but most of it was below. And I did one case in the past similarly where I did endonasal, and it was a difficult reach for me. So what I ended up doing was I did combine endonasal and endooral. And what I ended up doing mostly was leaving the endoscope in the nasal cavity and then working 2 hands in the oral cavity. And it was a lot easier with less sword fighting. And wondering if any of the panelists have done anything similar using
fortunately,
combination of stuff.
The soft palate can be mobilized, so you can even work from below if you want. So I think it's a good idea. Anyway, in my opinion, it's not so easy to work from the oral cavity with the endoscope in the nasal cavity. Anyway, maybe it's just a problem of setting in the OR.
Yeah, we've done something similar, Jim. I think the critical thing is if you can keep the incision above the level of the soft palate, and you can reduce your problems with volume loss and BPI and that sort of thing. But some of these lesions do clearly present lower. You know, we've seen the same kind of thing with a pannus. I've seen it with a hyperostotic lesion that's well below the soft palate. And so you just fall back on the endooral, and you can use a Crockett or Dingman retractor. We actually made a little retractor to open up the incision and hold it open as well endoscopically. But I think working below isn't terrible. It's not a dirty word any more than the craniotomy is a dirty word versus endonasal. You know, it's okay to go through the oral cavity if you need. We did it for years, as long as you can achieve a good closure. The problem I have is some of those masses that I've seen push forward below the soft palate. You want to go transoral to get them, and the mucosa and the muscle is very thin because this mass has been pushing there a long time. And so it's somewhat a little harder to get a good 2-layer closure when you're doing a traditional transoral or endoscopic transoral. You can certainly suture a lot easier down there, you know, when you need to. But I've done the similar kind of thing with combinations. Just matter where you move the soft palate.
Yeah.
Did you have other thoughts, Jim? Did you have any other questions for Davide?
No.
Anybody else have any questions or comments? I just have 2 things I'd like to bring up, if that's okay, Davide. Maybe 2 or 3. When do you find is an indication for tracheotomy when doing these kind of cases, or do you find there is one?
No, tracheotomy, I think if you go endonasally is not necessary in any case, I think, because you don't have that problem related to the transoral approach. So I think that one of the reasons to choose the endonasal approach, if possible, is to avoid the tracheostomy and nasal tube filling, I think.
Yeah, I would agree completely. And it's not necessary unless there's already airway compromise.
Another problem is if you have to face a pathology, an intradural pathology, you have a high risk of cranial nerves damage, and that is completely another stuff, obviously.
Right, the vocal cord or something,
Yes.
or if the pathology is extending so far inferiorly. We've had, I mentioned 11-month-old we operated that had a huge teratoma that was obstructing the airway and problematic, and so we needed to do that just so we could kind of work more safely.
In that cases, I think that you need a wide vision, and transoral approach is better.
Agreed. And then second to that, what about eating? So you do an approach like you've shown, and when do you allow the patient to eat and drink and that sort of thing?
And the first day after operation. No.
Right, so pretty immediate.
Yeah, yes, immediate.
Same, if the incision's above the soft palate.
The healing of the nasopharynx is very easy and very fast. Just few weeks later, if you check the wound is healed.
Yeah, completely agree. It heals beautifully. If you go back to
Yes.
endoscopy the next week or week after, you see that incision is well healed. And as long as you're above the soft palate, getting back to what Jim said, I think if you've got transoral, that's a slightly different story, because sometimes they can eat, particularly particulate food can get into that incision unless it's really well approximated. And sometimes waiting 48 or 72 hours just to let that mucosa start to close off can be helpful, because we're avoiding any kind of glue or sealants naturally in this area. And I think when you're above the soft palate, pretty much no problem. Another comment I had is for those that don't have a CT scan, intraoperative CT scan or O-arm like we have, and you guys have shown, sometimes you can use sort of another thing. If you don't have hardware in the way, like pinning and that sort of thing, you can actually pour some contrast into the cavity you've drilled, and you can just take an x-ray, and it'll give you some sense as to how well decompressed they are if you compare that to your preoperative x-ray. I know it's not sophisticated, but if you're in a jam and you need a way just to kind of look at your cavity, unfortunately, it doesn't tell you if there's some bone laterally or that sort of thing always, but it's one way to estimate that cavity if you just need some other trick up your sleeve, or if you don't have anything readily available and you really need to get any imaging. I often find you don't, but there are some limitations like Dr. Singh mentioned, or I've forgotten, maybe one of you mentioned anyway, where you on your surgeon's side where you can't quite see so well, you tend to leave some bone. That's tricky to do when you pour contrast, but if you need to get a sense of the whole cavity, sometimes putting some contrast, shooting an x-ray is fine. You can just suction it out and then keep working if you need. So just a thought for those who might need that sometime.
That's a good idea.
One other comment is the timing of the fusion. So we tend to do our fusion afterward. And in fact, I give the patient a rest for a day. So when we go in to do our odontoidectomy or tumor removal or all of the above, I will finish that situation. We have our way of closing. We use a midline incision, but a way of closing that. And then I'll just keep the patient in a collar and let them have a day of a break. What I found was turning them immediately over and doing the OC fusion, this got swollen and bloody, and it's not so good, even though it takes you maybe an hour and a half to do that fusion, or a couple hours maximum, depending how many levels you're going. We tend to stage them. I like to not have them fuse in the beginning because I want to decompress and then see where I'd like to have them aligned once I have that ability and they no longer have compression on their brainstem or on the craniovertebral junction. So we tend to do our fusion a day later. So I'll operate on day one, we'll give them a break and let them eat and kind of, refurbish a bit, and then a very quick operation for a fusion the following day. I found that combination was much better than doing one after that. And we've done them all. We did fusion first, we did decompression and fusion at the same sitting. We tried all the combinations, but I found that it was easier on the patients, and they were up and around quicker and they were nourished easier. And so that's just our habit, but I think both are acceptable, especially if they're in some position or they've got some big barrel chest. Sometimes it's hard if they're fused in sort of capital flexion to work easily here, depending on the location of the lesion. So just a thought, if that's of any help.
Yeah, Jim, we stage these also, like you said, but I actually leave them intubated overnight rather than having to do awake intubation.
I'll tell you, I haven't had problems with it, Jim. It seems like a leap of faith, right? But I haven't had problems. They won't pith themselves as long as they're awake, as long as they're neurologically okay. anybody that was really impaired, yeah, I'd be totally worried about them injuring themselves. But even just with a collar, they seem fine. They eat, they sit up, they do what they need to do, and then I bring them back down. And so I don't tend to keep them intubated. You might consider it. I don't know. It might be easier if they're intubated. You just go immediately back and start, but we don't tend to extubate them.
I'll tell you one problem I have run into was I think I have one or two cases where I did get into a CSF leak and you had to repair it. And then when you flip them over to do the OC fusion, they start pouring out because of the positioning.
Wow.
So you have to be prepared to, after you do the fusion, flip them back and then go back and just make sure the flap is in a good place and so forth.
That's a good test.
Yeah.
makes for a long day. Any other comments or questions from anybody?
Yeah, I mean, I
From
would just say
participants, there is a
that,
comment.
Dr. Deepajari?
There is a comment from one of the participants from India that the morbidity of the procedure is probably higher than the transoral procedure. I don't think so, but would anybody like to comment on that?
yeah,
What
so
I would just like to make one comment that what we do actually is do a combined procedure in many cases. We would definitely put a scope through the nose, but we are okay to instrument through the mouth in some cases where you need to really go down. So it's not a strictly endonasal procedure in that sense, and it works quite well actually. You get more freedom of instrumentation, more freedom of movement. Any comments on that, as well as Dr. Raj's comment from the participant?
I think I agree with you, Dr. Depujari. I don't think we should be dogmatic in saying, you know, the nose is better than the mouth. In fact, I did it through the mouth yesterday. I did both actually. And if you think about it, the incision is in the same place, whether you're coming through the nose or the mouth. The incision is over the C1 tubercle, a little bit just below it to get control of the base of the odontoid. And so the incision's in the same place. And I think this whole VPI issue really has to do with how you handle the soft palate and how you handle the pharyngeal muscles behind that mucosa. So if you microdebride too much of it, the muscles that is, you have a higher risk of VPI, and that can happen whether you're doing transoral or transnasal. Same thing with the soft palate. People used to say transoral had higher VPI because, and I think that was largely because of those who used the Menezes technique where you split the soft palate and you suture it, and so you potentially can injure it more. But a lot of times you could put a red rubber catheter, suture it, pull it up, and you're not damaging the soft palate. So I think there's a lot of myths, and some people even say, well, the oral cavity has more bacteria than the nasal cavity. And I spoke to my ENT colleagues yesterday. I said, is that necessarily true? Because when I used to do a lot of transorals with Professor Affelblom, we really didn't have any, you know, high infection rates. So I wonder if that's a myth that needs to be dispelled as well.
Yeah, I think that's true, Jim. And it's that volume loss concept. And if you've taken a giant mass out, then putting, like we said before, some fat or something in that space makes a difference in good handling of the musculature and the mucosa. I completely agree with you. I think the incision can be slightly higher and up more above the soft palate when you come endonasal. And I think there is some advantage to that part. But I agree with you. It's not that much different. I think that's very true. And I think the thing about the endonasal being much more morbid, and please, David, I don't mean to step on your toes. I'd like to hear your thoughts. But I think if you do careful preservation of structure and function, I don't think it's a terribly morbid thing to go through the nose. You're really just bypassing all these structures and making the incision in the back. I think it just takes a little bit of effort, so you don't need to remove turbinates and disrupt normal anatomy. I mean, please, you guys, go ahead if you could comment.
You know, this is our standard approach, transseptal, so is our workhorse. So for all procedure, even pituitary surgery or extended surgery, we perform a transseptal approach. So is our way. So I think one surgeon can prefer to go transseptal, someone else to go paraseptal, but if you are careful, there are no problem, I think.
And Harman, you've been patiently waiting. I'd like to hear your comments as well, please.
Yeah, I mean, I think I would like to add that, since I've been doing the odontectomy endonasally, and we have about 8 cases in the pediatric population alone, they have all resumed diet the next day or the same day, and they have all been extubated, which was not my experience when these were done transorally. So the incision is much higher when you're coming from a higher plane. You're looking down on it rather than going transorally. So I think there is an advantage to it. It's obviously a little more restrictive, and we do the both the posterior fixation and the anterior approach the same day. In fact, we do the posterior first, the fusion, and then do the anterior. The one thing that we have to be careful about that, we have written is that when the posterior approach is done first for the fixation and you're decompressing, sometimes surgeons will have those patients a little flexed to makes the decompression easier posteriorly. But when you're fusing them, you have to then scrub out and put them back in a neutral position, because if they are translated back and you fuse them, or they're flexed and you fuse them in that position, when you do the oral approach or the endonasal approach, they can have airway compromise when you're extubating, because they're not, or swallowing problems because they're not fused in their normal anatomic alignment. So we actually take a picture of them sitting up or standing up and then see where the alignment is. And then we try to recreate that when the fusion is being done, so that you're not fusing them in a translated position where they have problems swallowing after. So just a couple of pointers to keep in mind for the,
In that case, Harman, why not do the fusion secondly then? You have concern about destabilizing them up front?
Yeah, for the same reason, I think it just works out better with our workflow. Like a lot of things that the surgeons, they will do that one first. And then also, if you do end up with a CSF leak, like Jim was mentioning, it makes it, easier that you're not flipping them prone after, and that causes a problem. But I think you can go either way with that. I'm not dogmatic on that. That's just our workflow where we are doing the fusion first and then the oral portion or the endonasal portion after.
Okay, good. Very, very good comments. Great discussion, guys. I'm hoping that's helpful to the participants as well. I think in the interest of time, Domenico, we've been patiently waiting for your presentation. I'm looking forward to it. I'd like to turn it over to you now.
Thank you. Thank you very much. Thank you also to WFNS committee for having me here. Oh, sorry. Just share the screen. Did you see that?
Yep, that looks fine. We can hear you and see your slides.
Okay, thank you very much. So I want to start with this consideration coming from one of the big names of transsphenoidal surgery, one of the mentor of our school, that is Dr. Laws, and he said like that the only way like to avoid the complication is to not do any surgery and to wait. So only like trying to go and understanding the disease and the anatomy, of course, you will get through it. And also this one, like only to introduce the school of Napoli, you see we have 3 deities. One is the volcano that is called Vesuvio. The one is Federico II. And suddenly I have to show you this one that is Diego Armando Maradona among our deities. So we started in 1997, Professor Cappabianca, and we had to adapt our strategies to a new way of understanding and moving instruments as neurosurgeons, because we do not use anymore the transsphenoidal retractor, and we are using like these new instruments of visualization that is called the endoscope. And as I asked like before to Dr. Liu, we use the instruments in a 2-hands technique with another surgeon moving the endoscope. And so first we have to start from the anatomy, and we had these 3 masters, Dr. Chabisher, Dr. Castelnuovo, and Dr. Prats, and this is my fellowship that started from the lab, as any one of you. Like we spend a lot of time in the lab dissecting and knowing, because you see like tiny tilting of the endoscope gets you into new words and new experience that are completely different from the adjacent areas, one from each other's. So also you have to know what you are working with. This is the last camera, HD camera provided that we are using regularly in our OR, but we have also tried a new experience, because nowadays innovation is coming very fast, and there's also the possibility of using like a 3D endoscope that gives you like the better view, the sense of that, but still you need like glasses and you have to adapt to it. Nowadays, there's also this other opportunity with 4K that has been used first into the gastrohepatic surgeries, and we're trying to move to it. And then there is, of course, the technique, the area, and the surgery we are dealing with. We start with this kind of surgery, like we call the standard approach, and it's made of 3 different phases. You have to know perfectly which are the tricks among the route that starts from the nasal step, it goes inside the sphenoid, and then moves to the cellar step if you're going to a regular hypophyseal surgery. And this is the door that one should pass through. But it is not adequate like to leave at a door. You have to enlarge your corridor and to manage your structure to have like the proper view and the proper instruments maneuverability. And you know, we are all neurosurgeons. The first trick and the first difficulty that we might have encountered along our process, it is the lateral wall of the nasal cavities. It is not as flat as it is the nasal septum. It is made of very, very different and complex structures. This is the turbinates, the ethmoidal complex, and the depression and molding made by the air along the development of the facial bones. So the first thing that to avoid complication is try to fix your guiding points, like and to identify at any surgery, either in the lab or in the practical, in the clinical practice, your orientation. So if you're inside the right nostril of the patient, you have to identify the choana, recognize that there is the middle turbinate on your left side looking at the screen, and then you have to eventually identify the ostium. The opposite way, in the mirror, it happens in the left nostril. You recognize the septum, you recognize the choana, you recognize the sphenoidal recess, and then you look up to the sphenoidal ostium. And this started a few years ago, maybe, but now we have another important key points to show up. When you're looking for distraction, where you're focusing your attention to the points where you might enter the sphenoid sinus, nowadays you have to find out like the proper space to leave these 2 feeders intact, because like one of the most important aspects of the reconstruction at the skull base, it has been made up by the 2 Argentinian guys, Haddad and Bassacastegui, that defined along with Kassam the use of nasoseptal flap, and it is based practically on these 2 tiny arteries that comes from the sphenopalatine, from the maxillary artery, and feed all the septum. That should be vital when you place it back on it. So if you look decently like at the anatomy with a close-up view, you identify like these branches coming out from the maxillary arteries that comes inside the pterygopalatine fossa. And you see nasopalatine artery and posterior nasal artery coming all over the roof of the choana and then like feeding the mucosa of the septum. And here there is a little video that started like showing an experience that, of course, it is very frequent, like, and it is like the eventual breaching of a vessel. Maybe it is a little slow. 2 instrument technique. We are in the right nostril. The video is working very bad. Scattering a lot. And then you see you're biting off the mucosa. You did not yet identify the proper structures. And it might end with the bleeding. Very poor quality video. So we go over. Okay, and of course we just had like the injury of a tiny artery that we fixed with bipolar cautery. Otherwise, the retraction will oblige you to go inside the pterygopalatine fossa and eventually infratemporal fossa to manage it. So this imaging again like shows that you have to achieve the proper space. This comes from the Dr. Kelly, and it shows you like that to show properly the posterior aspect of the walls of the sphenoid sinus, you have to enlarge properly the anterior wall of the sphenoid sinus, and then have a complete exposures in between the intercavernous sinus above and downwards and the two carotid arteries on both sides. And you see here, like again, like case that Dr. Kelly showed us several times, like a very, very tiny removal, like a sort of pinch, because the wall of the sphenoid sinus has been not opened. And then, like, to avoid complication, you have to know this type of anatomy. Maybe you have noticed that Dr. Leo has this proper view behind his screen, and we just like you to focus on the vascularization, like the tiny vascularization of the pituitary gland, of the pituitary stalk, and of course of the posterior pituitary gland. Why? Because if you chop off like this tiny vessel, probably you will not encounter like a severe hemorrhage, will not have like tremendous neurological problem, but for sure you will get your endocrinology get mad, because you destroyed the gland activity, you destroyed like the posterior gland activity, and you ruined the quality of life of the patient. So I show you a video again. It's getting me mad. Okay, this is a GH secreting pituitary tumor. We open a like tiny dural bridge over. We're trying to do again like the pseudocapsule also in non-ACTH tumor, but you see like the tumor is very soft and it has been pushed away by the space. And you see here like the cavity. You can go close with the endoscope and you recognize the very, very reddish signal of the pituitary gland that is intact, the middle wall of the right cavernous sinus, and the part of the diaphragm macella that it comes into view. But be aware that there is something that you might take in consideration when you are going into the lateral spaces. You are using sharp instruments like blades of knives, like Carrison, cautery, or whatever you use like to open the floor of the cella. But look how close is the carotid artery, and you know that it might have like different bending all along its intercavernous sinus. So always before opening, like don't forget about the big red. Like Dr. Leo is looking back, and there are on both sides the big reds, and you have to identify before opening the floor, the dural floor of the cell, and eventually you might have like a good supply with these instruments that are microdoppler probe that you can push and you can touch the course of the carotid artery and recognize before opening the dura. Because sometimes, you know, also the neuronavigation will not do an exact eventual figuration of the carotid artery. And eventually, you can also use the proper instruments. If you have like banded and protected tip instruments, it is better like when you have like a paramedian exposure, like to use and to move from the lateral aspect of the opening toward the middle portion of the opening. And this is a view again from our university, and it is to remind you that the endoscopic extended approach removed our frame, so it gets like a very, very tiny and oriented view all along the skull base. But of course, like you have to deal with different modules and different complications. Because why? Because if you opening here the transcribiform plate, you have to identify the limits, and the limits are like 4 arteries: the anterior ethmoidals and posterior ethmoidal arteries. And if you don't mind to these tiny arteries, it might happen that the arteries retracts and starts bleeding inside the orbit, and you will have like an intraorbital hemorrhage. Again, probably one of the most used approach nowadays to deal with the hypophysis hypothalamus diseases, it is the transtuberculum transplant. We tried also to give some mathematic meaning to this that we call nowadays suprasellar notch, and just gives you like a window, like the proper attitudes to open the windows and to the things that you might focus on when you are performing that kind of approach. And you have to measure properly, like to in your mind, you know, setting like the sphenoid sinus configuration, especially like it is not well pneumatized, like to find also on the MRI or like in your mind what is called the suprasellar gate, the point where you enter the suprasellar space or the intraarachnoidal part of the tumor. Just remember the optic chiasm and stalk position in regards to the tumor and the vessel encasement. So this only like to recall the attention, like in about like all these are very tiny tumor involving the tuberculum cell area, but look at how the different it is the angle in between the planum sphenoidale and the cellular floor, and look out the tumor that is not that huge as compared to the previous one, just bend over the planum sphenoidale and just force you to manage a different corridor, although the sphenoid sinus it is adequately pneumatized. And then what we call, what Dr. Kassam called like the suprasellar gate, the point where you have to extend laterally your opening of the dura to be sure to manage properly, especially meningioma that sometimes invade the medial aspect of the optic canal, and it gets you a direct access into the supradiaphragmatic space, so you're sure to deal with the supradiaphragmatic component of the tumor. And you can also measure here with a CT scan, like to define and reconstruct in a 3D space, which is the point and which is the amount of bone that you wind up removing into your surgery. This is another concept that also might be very useful, that is called like the working area and surgical freedom, and it defines like the maneuverabilities of the instruments when you are opening your suprasellar space. But backing again to the practice, like you, although there is not always the possibility to identify the position of the chiasm and the skull, you have to find the possibility to define your corridor. You see here, you do not see the stalk, you may see here like the optic chiasm, so you have all this corridor at your disposal. You go forth and you go below the tumor, you identify the chiasm, and only at the end like dissect the final part from the vessels above the chiasm. Here it is pretty a different situation. You have like a recurrent tumor that has pushed down all the chiasm and the nerves. You do not see anything above here. You see here the anterior complex, and you see here the chiasm. When you open the dura, it immediately will face into the corridor, and you will be preferable for a surgeon to go below the chiasm and use that corridor. Again, like it is possible if the tumor is soft, like to identify the stalk in craniopharyngoma or meningioma surgery and to release the stalk in between and move on one side or the other side. And this is a very nice consideration, like coming from the group of San Francisco. Like if you are a vessel encasement, especially at the ICA or the tiny vessels above the chiasm, the corridor will not make the difference. The real difference it will be made when you go from below, like that you will release immediately the chiasm and you will have like a better visual outcome, but the extent of removal will pretty be the same. And of course, like the biology of tumor. And I will show you some cases like of complication. This is a very huge adenoma that was involving the third ventricular cavity. You see that his prolactin level were very high, so the endocrinologist just started with cabergoline therapy, and after 2 weeks, the guy came back to our hospital with this CT scan at the admission, and it was comatose. And we had like an emergency surgery. We had EVD shunt. Just a second, I will start the video. And again, this is a forehands technique. You see, very bloody corridor, like also the tumor was very soft, but it was completely with the hemorrhage inside. And we performed like a 2-corridor approach. Like first we have dealt with the inferior part inside the cella, and then we just followed the tumor that was made with these big clots of blood inside the third ventricular cavity, just only with aspiration and trying to pull out the tumor. And you see here, like the ventricular cavity with the foramen of Monroe and the floor of the third ventricle. And at the end of the surgery, of course, like reconstruction as for any extended approach. So, another case like of severe complication, it is again like a recurrent tumor with a invasion not only of the supradiaphragmatic portion, but quite a large lateral extension with invasion of the brain tissue here at the level of the frontal lobe. So you see here also in the posterior part toward the posterior aspect of the cavernous sinus. That was a recurrent tumor, so we started again reopening the flap and keeping the flap here, like you see, like enlarging the breach. You recognize like the dura, you try to extend furthermore above the bone opening, the dura opening, again, like as an extended approach to expose also the suprasellar and supradiaphragmatic corridor. The tumor again was soft. I will move further. You see here also we use sometimes the CUSA also for adenomas. We try to inspect. Here you see like the brain tissue, like not pushing at any time, like trying to remove and try to identify the brain tissue and the arachnoid that this corner was not that clear. Like an endoscope at the end, like to check out if there was something in the most lateral right aspect of the tumor. You recognize the chaos, you recognize this arachnoid, and then you have reconstruction as per the approach with the nasoseptal flap. So again, like a complication, you see here, like it had like a big hemorrhage due to a residual piece of tumor, and few days after developed like a plegia of the lower limb, of the left lower limb. And when we went for an MRI, we find out that there was like a subischemic area, and we did completely misunderstood this phenomenon, of course, of vasospasm that might happen, like also in transsphenoidal surgery. Again, has been reported more than once, and in that case, it was probably the cause of the severe deficit of the patient. And one thing that might be of interest to try to avoid the complication, it is the transpterygoid cavernous sinus approach that's been showed like very, very nicely lateral aspect today. And it is all about the carotid, of course. Like we have to identify the carotid again. Like our problem, it is like to recognize it, although you are not still managing it. You see here, this was one of the first cases in a GH patient. Like we were removing a spur inside the sphenoid sinus, and the carotid start to bleed. And it really helps you if you have like your angiosuits and your neuroradiologist nearby to try to fix the problem inside the interventional neuroradiology. What we have to do before is like again, like to recognize which are the possibilities that gives you the anatomy and which are the possibilities that are determined by the tumor that is involving this area. Usually, if you are in the lab, you recognize two corridors that are the medial corridor to the carotid, and you can have like also a lateral corridor. If you're entering the medial corridor, you have to be focused on the third nerve and on the inferior trunk, like the meningohypophyseal trunk that gives you like the inferior pituitary hypophyseal artery here. But if you go to the lateral corridor, you have to be prepared like to manage all the nerves that are moving towards the foramen, like to the superior orbital fissure or to the foramen rotundum at this level, and also of these tiny fibers of sympathetic jumping toward the sixth nerve. And our colleague Danny Prevedello just trying to define like which are the possibility as seen from below, as we know the triangle that has also been shown before, you can recognize at least safe areas that you can enter, and then you have to expose by drilling and removing the bone off the nerves and to identify which are the landmarks to enter this area. See, you will have like a space in between the carotid artery and the Geiserian ganglion. You can have a space in between V1 and V2, and then finally in between V2 and V3. And of course, like things moved a little from that, and you see that many other contributions came out, like to identify which are the possibility of this corridor in endoscopic and nasal surgery, and you see how also it is tricky to define properly the route of the carotid. And my favorite, and in terms of pituitary surgery, it might be this one that came from the group of Pittsburgh, and it has been written by Fernandez Miranda that refine the classification of the cavernous sinus, because it is not anymore worth in saying like you are dealing with the medial aspect of cavernous sinus or lateral aspect of the cavernous sinus. You might identify 3 compartments of the cavernous sinus that has been involved by the tumor. And we will have like an inferior compartment, as in this case. We can have like be involved like in a superior compartment or in between the C-shaped segment of the intracavernous sinus carotid artery, or like you can have like tumor invading the posterior compartment just toward the posterior fossa. And again, like Dr. Kelly that trained me also, like gave me this case to show how it is nice and it is important to recognize the anatomy, and how maybe the lesion can help you while you're dealing with this area, because your trick is to recognize the carotid artery, and then you can go and remove the tumor, respecting the compartment, respecting the artery, and following the breach that the lesion itself has created. This is a video, again, from Dr. Kelly that, again, is not okay. Okay, I'll skip the video. Okay, it started. You see, basically this is a standard approach. The opening has been made with the help of the microdoppler flow that recognizes the most outer aspect of the carotid artery. So you see, once you have recognized the course of the cavernous sinus, you go back inside, you place your opening above the dura in between the medial aspect and the lateral aspect of the tumor. The tumor, it is an adenoma. You open adequately the dura, you move safely with these instruments, and you will not injure the carotid artery, and then you start your dissection with blunt instruments. You see here, like you have again the carotid artery that you previously recognized. At the end, if you go closer, you got supracellular diaphragm here. You start opening at this point. You see carotid artery here. You can open the superior aspect, because here you have the carotid artery, the first horizontal tract. But you can open here where there is no carotid artery, and you have like the clinodal aspect of the carotid at this level, so you can safely remove all the tumor from this component. And then again, like below the tumor here, with blunt instruments, with a close view, you have like the middle of the cavernous sinus with the carotid artery coming off, like the paraclival tract here. Again, all the nerves inside. There is nothing that you have to fear at this point, because you have all the anatomy exposed into your view, and then you can reconstruct. So further instrumentation, you can have here like navigation before starting, Doppler again, and of course like suction, and be prepared with your coronary arteries to eventual things that happen, and of course prepare your surgery. Be with fat and muscles available, with gauze, sponges, and everything that it might help you to stop the blood. And of course, like as I said in that case before, like your interventional neuroradiology is fundamental. Very few things about the transcribal CVJ. We had like a wonderful presentation from Dr. Milani. I only would like to show you this, that is also a trick coming from the Dr. Prevedello schools, that is called the rule of 3. Be aware that are like the nerves. When you open the clival dura at this level, you will have the third nerve in the first third of the clival dura. The second third will be like managed, will be properly coursed by the 6th nerve, and then down in the third third you will have from the 9th to the 12th nerve. But probably one of the most threatened complication and the feared complication for us, especially in the beginning, it has been like the skull-base reconstruction, because it is very difficult. Like, and it's not anymore like a cellular reconstruction where you have like microadenomas, and sometimes you do not have CSF, so you have only like to protect the cistern and eventually pack the spinal sinus and the sella. You have to deal with the opening of the cistern, so you have like to perform a multi-radial reconstruction. You have to deal with every one of the spaces that you have opened. So you have to fill the intradural space, close the osteodural defect, and eventually like fill and pack the extracranial compartment, aka also the sphenoid sinus. Nowadays, we are adopting this technique that we call like 3F, according to Dr. Cavallo, and it is made of the use of flat, the use of flap, and a fast mobilization of the fascia. I'll show you a video, like to have a proper trick of it. You see, like this was a craniopharyngioma, and of course, transtuberculum transplanum approach. We first place a big chunk of fat harvested from the periumbilical space of the patient. Then we have the patient that has a Valsalva maneuver. So if you have an exceeding part of fat, it will be pushed away and it will not clog and it will not press against the nerves. Then we fix it with a tiny layer of glue, and then we lay down our nasoseptal flap, and then we fill the cavity with spongosan or eventual other material, with Susicel and so on. So if I might have some consideration to say, is like to be prepared like to the cases that you are facing. So first you get the knowledge and then you choose the case. And of course, like if you have proper knowledge, you have to be prepared like to choose the appropriate case and to identify the dangers that are along the route and plan, and of course plan again and plan a third and fourth and fifth route. And this is our last consideration, that sometimes the intelligence beats sides and avoids you trouble, and be prepared as like to have a great team, like a really great team. And I would like to thank you all for the patient.
Fantastic. Domenico, thank you very much. Very salient points and very
Thank you.
important, I think, for people to know. So thanks so much. Great presentation.
Thank
Does
you.
anybody have any questions or comments for Domenico?
Hi, Domenico. And congratulations on a beautiful presentation. I had a question about the fat concept, and I've heard Luigi say this at a recent international meeting I was on a panel with, and he was mentioning how he would do reconstruction with fat only and then sit the patient up. And in your experience in your center, very little CSF leak. And so I tried doing that once in a recent patient who had a cribriform defect. It was a sinonasal cancer. He had been irradiated. It was a combined approach. So the pericranium was gone. The nasoseptal flap had been used. So no good tissue. And we did fat. And I tried to sit him up, but unfortunately he kept leaking. So we published this, we ended up having to do a paramedian forehead flap and then just bring it down into the cribriform, and it saved his life. But I'm interested in your comments about fat and sitting upright.
We are using a lot, like always, we are using this technique in transtuberculum transplanum approaches. So we go for the use of fat, probably Luigi told you, like a corkscrew. So the fat basically goes through the osteodural breach and it fills the space, the intradural space, but also like clog the breach, like it stays in between the dura and the outside part. And then it is only fixed with fibrin glue. Our concept of making, and then it is covered, of course, with the nasoseptal flap. Our concept of making the patient walk is like to reduce the intracranial pressure. I mean, like if there is no other concerns, we go for a CT few hours after surgery. If there is no other concern and the patient is doing well and it can be walking, it is a further tool, advice that we are giving, like to reduce intracranial pressure. To be honest, the things that I read you, like on the fore part of the skull base, we never tried. We never tried in the cribriform plate. So it seems that at that level, reading the literature, it is preferable like to have at least a button technique or at least an intradural placement, especially in the case where there is a malignancies and you have to go for radiotherapy and eventually do several other approaches. But our experience so far does not include yet the most anterior part of the skull base. I don't know if Luigi is connected. Maybe you can open the microphone and he can give personal, or if he is listening and he comes here, maybe.
I don't think he's on. I don't see him listed on the participants.
Maybe yes, but I am with the door closed. Maybe he will arrive. Otherwise, I don't know if I just give you adequate response to me. Oh yeah, here it comes.
Oh, that's funny. He's watching. He's watching.
Hi, James. So
Hi.
I have not so much to say. I think Domenico already explained what is the concept behind this technique. We simply use a single large piece of fat as a cork stopper, because one of the possible problems when you use fat is that if you use a small piece of fat, they can migrate. I agree with the colleague that if you use a small piece of fat, they can migrate inside the ventricle, through the cistern, they can spread away. But if you use a single large piece of fat and you encase across the skull base defect, it will work like really like a cork stopper. And in our experience for the suprasellar space, it seems to be the most effective way to close the defect, especially when you have optic nerve or carotid around your skull base defect. Of course, you have to cover that fat with the nasoseptal flap, because if the fat is exposed to the air, you can have some infection or other problem. So it's not just fat to close, fat plus the nasoseptal flap. But in our experience, really, especially for craniopharyngioma, in which in the past we had a lot of problems, like everybody, you know, with the craniopharyngioma, was not so good, the result with the CSF leak. And especially in this disease, the result now seems to be really good, really, really good. We don't use any more lumbar drainage, even in patients with intraventricular extension, for example, no? Or irradiated patient. So really the result seems to be good. Now we have collected around 100 cases with this technique just for a suprasellar approach. We did not include the factory groove or other extended approach, and the results really are good, really are good. So this is the reason why we are pushing so much this technique.
Thank you so much, Luigi. I appreciate your coming back on. And it's always great to see you. Does anybody have any other questions or comments for either Domenico or Luigi?
I want to say hello to you, and Domenico is coming back.
If I could share my screen for a second. I have just 2 points to make about craniopharyngoma. If I could just for a minute, I'm going to try to share this. Can you see my slide okay?
Yep.
Okay, so I just want to make just a brief point about pediatric craniopharyngoma. I think 2 points that sort of came up that I think this might be helpful. I won't show all these things, but this is just a young 10-year-old male that came with diplopia and bitemporal hemianopia, headache, nausea, vomiting. He actually had hydrocephalus. In his imaging, he's got a large, typical-looking craniopharyngoma and obstructive hydrocephalus. This is one of the examples of a patient that was shunted and then sent in to us. And this is what he has, pretty typical looking, craniopharyngoma. He's got a shunt on this side. That's why he's decompressed. But one thing to look at is his optic chiasm. And I know a paper just came out recently saying that this is a contraindication for endonasal surgery when the chiasm is sitting down on top of the gland, when there's really not much space. The tumor is totally retrochiasmatic. And if I can just show you this video for a second, if that plays okay. Our typical approach, and you can open the floor of the sella, the bone, sometimes will help the cella to settle a little bit without having to do any transposition or put the gland at any additional risk. But anyway, standard openings, you can see transtubercular. And when you see this open up, you'll notice the optic chiasm is the first thing you see, and it's sitting exactly on the pituitary gland. We make a very limited opening, just need to see the chiasm. I don't need to see the whole frontal lobe, etc. But you can see this chiasm is the first thing you run into. And we're going to open our cisterns and sort of be patient and try to gently develop the space between the pituitary gland and the optic chiasm. Again, sparing the vasculature, you'll see this one small hypophyseal branch that goes actually across the chiasm right into the tumor. So that kind of branch we can take, but anything else we need to spare. A little bit of blood here, subpial blood, you'll see it just resolves and goes away. It's really not a contusion of the chiasm. But if you gently work this tumor and start to debulk it, work the cisterns and open up, you can see how much great space we can get. Even 4 or 5 millimeters here can give you great access to this tumor when the chiasm was initially laying right on top of the pituitary gland. And you can see you can get a great working space. So just in case if you're discouraged by having the optic chiasm down on top of the pituitary gland, you can actually work the space out quite well. I'll just jump ahead. You've seen plenty of these videos. I'm just going to kind of skip along here. There's always the nice ones of us pulling the tumor out. And I never get tired of looking at these tumors, whether JNAs or whatever, coming out the nose or coming out the oral cavity. I think I could watch those kind of videos again and again, as Jim was showing a minute ago. It just never seems to get tiring. But there's that. And then if you look at this kind of thing, talking about repair, this is our button graft. And we use a 2-layer repair. It's a very simple thing, fasciolata or synthetic, which we tend to use now. We've got a very robust series of these and have minuscule leaks that were mainly only in the first third of the series once we figured out how to place things. And that inlay part of this is 2 layers sutured together. And the inlay part sits in the turgor pressure in the brain, and the spinal fluid really kind of push it down against the cranial base. And you'll see as this thing's sitting here, it's really not leaking at all around it. It's just sort of pulsing like normal dura. It sits beautifully. And then we put our nasal septal flap on top like the rest of you. And that simple technique with preserving the turbinates, not using lumbar drain, not packing any fat in place, our button graft sits just here. It also can be used around these delicate structures like the optic chiasm, optic nerves, and doesn't require any rigid buttress that would limit our opening or require us to put something firm up against a critical neurovascular structure. But we've got our button graft here, you see a nasal septal flap and a nice cavity from removal. And this young guy had complete recovery of his vision, resolution of diplopia and hydrocephalus. Did not get a shunt infection, fortunately. As I said, he came with a shunt, and he's had no recurrence. He's going on his 6th year post-op now. But I think that's something that's useful. But just 2 things to think about: if that optic chiasm is low, you can often work enough space. And there are other options for reconstruction. So unless there's any specific questions or comments, I think we've gone quite a good time here today. And I want to just once again, if I could, to thank the WFNS. And I want to particularly thank Dr. Qureshi and Dr. Deepajari for inviting us. This is an excellent educational series. I've enjoyed it. I know that I'm sure the participants, the speakers, enjoyed it. And I appreciate everyone taking time out of their schedules to do this. It's really a critical part of education right now, certainly during the pandemic. I'd just like to wish everyone a happy holiday and a happy new year. And I hope that everyone is staying healthy going ahead. So thank you very much. Dr. Deepajari, Qureshi, any final comments?
No. Thanks, Jim. Thanks, Dr. Evans, and all our speakers for the day, Dr. James Liu, Dr. Harman Singh, Dr. David Milani, and Dominic. I think I'm terribly sorry I joined late because I had to go in for an unscheduled kind of an emergency case. And I'm sure that all of you enjoyed the interaction. And these sessions are recorded and they will be available on WFNS web space, which is being, a page is being created for the Neuroendoscopy committee. And I hope some of our participants who could not, and you can probably make people aware of this, can make use of this resource. I think though this pandemic has created a havoc and has made it difficult for us to travel and meet, these are some of the opportunities apart from your lectures, we also get to at least see and talk to each other. So I am very happy for this opportunity, and happy holidays. And we have another program end of this year on 18th of December before we close this year. So hope some of you can join us for that as well. Thank you.
Thank you, everybody. Take care. It's great to see everybody again.
Thank you.
Bye-bye.
Thank you.
Bye.
Okay, Chandrasekhar, I can see you here. All right.
Moody, thanks. Sorry. I just saw your message.
No, that's fine. No, we're good. You said everything. I just want to thank everybody, and I was in and out, so I just rejoined. I saw you online, so I said that's
Fridays
great
are
because I
getting a
needed to
little
go.
difficult
But
now that the work has started. But let us see.
great.
We'll plan something to make it more easier.
No, it's
Thanks,
great. Super.
Domenico.
Thank you.
Thanks, David, and thanks our American friends.
Thank you very much.